Okay, recording will start soon. Think we are recording. So I am Shannon Bloom. I am a licensed marriage and family therapist and an eating disorder specialist. I have been working at Connections since 2021, but I've been a therapist since 1992, kind of a long time. And today we are going to go over, Sarah and I are going to go over when to know it's an eating disorder. Is it disordered eating or an eating disorder? So Sarah, why don't you introduce yourself just a bit so everyone can get to know you a little bit too.
Yeah. And I am Sarah. I am a registered dietitian. I have been a dietitian now for about 3 years. I actually have experience in the eating disorder world, working at residential level of care. And then also prior to becoming a registered dietitian, I worked with providers in the eating disorder world as well. So getting some of that background even before I became a provider myself.
Nice. I forgot to mention also that I did work for almost a decade as well in the eating disorder treatment culture. I was a therapist at a PHP IOP, and then continued to see clients that had eating disorders on an outpatient basis before transitioning to Connections. So we both have a good amount of knowledge, and we thought that this would be a helpful way to get some information out there because clinicians and families alike are confused, right? We find this, Sarah, when you and I do a lot of chatting about clients and treatment, that sometimes we underestimate what's happening and we think it's not that big of a problem. And it turns out to be an eating disorder. And then other times we might think that it's an eating disorder and it's actually just an element of an eating disorder. So that's what we're going to get into today. In terms of what we're actually going to go over, I just mentioned we're going to differentiate between those two aspects, the eating disorder versus disordered eating. We will provide information about what are the different types of eating disorders. They have a lot of overlap and there are some distinguishing characteristics. We will talk through risk factors, warning signs, give a brief information about the different levels of care, because depending on the severity of the eating disorder, there's going to be a different treatment recommendation. We also have some resources and support links, and then we have a ton of statistics and information that's not quite as exciting to go over, but is very informational. And so for whomever would like that information, I believe that we're making the slides accessible. I'm not entirely sure, but we can certainly get that information for you if the slides are not going to be helpful. Sarah, why don't you hit this point?
And then looking at the objectives, there are going to be 3 distinctions between disordered eating and the eating disorder that we will cover and review. And then when we're looking at the specific types of eating disorders, we're going to look at the 4 primary types. There are other types out there, but we're just going to focus on the 4 primary. And then we're also going to discuss the risk factors and the warning signs of eating disorders. So then that way you can clearly know like what you're looking for when, you're seeing these behaviors come up in your child or maybe a friend. Even for yourself. And then we're also going to be talking about the different levels of care. If someone is diagnosed with an eating disorder, what level of care would be appropriate for someone with an eating disorder. And then also, again, looking at, okay, now we know we have an eating disorder, and so what kind of information and support is out there to help with these things. And then like Shannon said, a lot of statistics there at the end. So that way we just have that information.
Yeah, we're not going to go through, I mean, when we say we have a lot of information, I think it might be like 8 slides.
Yeah.
So we're going to just let you know that we have different research-based statistics that are telling us the who, what, when, where, and why of eating disorders, and really like the thin culture influences, the diet culture, the clean eating. But we're not going to dive into that by slide. That would take too much time. So Sarah mentioned that there are 3 different elements when we're discussing and really differentiating between, do I just have some level of disordered eating, or do I have a full diagnosable eating disorder? When we are looking at this, we want to tackle and pay attention to 3 primary elements. We're looking at behaviors, we're looking at obsessions, which is a thought process, and then we're looking at the impact on functionality. So we're going to go through each of these. Sarah and I are going to take some turns going through how this looks so that you can get a better idea when you're like, oh, do I have this or do I not? These are going to be the 3 pillars that we would look at as clinicians and we want you to be aware of. So Sarah, why don't you hit this one?
Yeah. So when we're thinking about behaviors, I think this is where it can feel really tricky in today's society of knowing, like, is this disordered eating? Is it an eating disorder? And even a lot of these behaviors are so normalized in society that that can be a really tricky point as well. So when we think about behaviors, we're thinking about skipping meals, eliminating food groups, some of these things that are very normalized in society that are actually big behaviors in disordered eating and even eating disorders. And so looking at when it's disordered eating, you may see like one of these behaviors, like maybe someone starts going on a diet, and so they start counting their calories. And it doesn't really impact, that's the main behavior that they're engaging in. Yeah. When we get to an eating disorder, you're going to notice that there are multiple behaviors going on. We start counting calories. We're also skipping meals. We are also cutting out huge food groups, and our variety becomes very limited. So you're going to start noticing multiple of these behaviors happening at once. A lot of the behaviors are going to involve food with eating disorders. Mm-hmm. So whether that is also like eating large quantities of food in the evening time, and then also that exercise piece of, you know, excessive exercise, feeling like we have to exercise for hours every single day. And then the impact it has on the body image. And when we're looking at behaviors and distinguishing between disordered eating and eating disorder, we're also looking at how often is someone engaging in this behavior? Mm. What is the severity of the engagement? So like, is it happening? Is it really, you know, like the variety piece? Are we cutting out like where we have 10 foods that we're only going to eat now because these feel safe? And then how long has this been going on? Has this been a week, or has this been going on for, you know, a few months now? So looking at those things, and also knowing a lot of people have a lot of emotion behind these behaviors. And so knowing that these behaviors may not be showing up in the light, they may be keeping them secret, doing them when no one is around, or trying to schedule a way to where they're not around people in order to engage in these behaviors. I feel like that's really the food piece, but Shannon, did you have any?
I also was struck when you were just talking about the emotions behind it. I will say that sometimes we could notice like if there's a lot of justification or explaining behaviors, that could be a hint that there's some emotional dysregulation around it. So if a parent, for instance, is noticing like, gosh, it seems like you haven't been eating your lunch when, you know, it comes home in your backpack still, or something like that. If there are lots of reasons why, oh, I had to study this week a lot, or, oh, I got called into so-and-so's office a lot, that could be an indicator that they're avoiding the feelings that they're having about skipping, and they're coming up with lots of explanations. This can be really tricky because as parents, we're going to want to, naturally, we're going to want to believe the lower level kind of explanation. So I would say just look for patterns of that if that's happening frequently. That could be just kind of like something might be happening there.
Yeah.
Yep. Okay, the obsessions part, this is where we really want to be aware that you're going to move, if you're more obsessive in your thought processes, you're going to be tipping into the part of the spectrum that's more on the the eating disorder, excuse me. If, like Sarah said, the frequency is just not that significant, it happens maybe, once a month, or maybe when somebody's ill, they're just not eating, and that's a legitimate reason, and then they go back to eating breakfast or lunch. But if they're obsessing about it, if the thoughts are generally all consuming, or even a majority of their time, typically we find clients that have eating disorders, 50 to 60% of their time, or their thoughts, if they were going to do a percentage breakdown of the thoughts, is about food, size, weight, and appearance. So if they're thinking about calories, if they're planning excessively for what they're going to eat at the next meal or how they're not going to eat at the next meal, so food avoidance, if they're pretty obsessed about the exact brand of food that they have to have, these are obsessive tendencies that lead to very rigid thinking. So we want to be very alert to that. If they're also evaluating themselves really harshly, how their size, their proportions, their weight itself, and they're obsessing about it, this could also lead to the compulsive exercising. And all of this will really impair one's ability to be present in our life. So a kid might be with their friends, but if they're obsessing about what are they going to do when the pizza comes out for dinner at the party, they're really missing out on the interactions. Now, you're not likely going to see a lot of the obsessions because they're internal. And so this is where talking with our kids or a partner, if it's an adult, is really important. And it can be very challenging because, like Sarah mentioned before, there's a lot of emotions around this. There's often a lot of shame with how my body looks or how it's functioning that leads us to want to change it. So we do want to tread lightly, but we also want to tread. We still want to go have the discussion and have uncomfortable discussions around this if necessary. But this is going to be a key element to really see if we're getting obsessive. We're probably leaning more towards an eating disorder than just something that's a little off in a pattern, one element. Do you have anything to add on this at all, Sarah?
Yeah, what came to my mind was also thinking when talking about that obsession, thinking about this really impacts where I see clients where they're continuously looking up the same information,
Yeah.
like over and over again. So some of these things may be like they're looking up their BMI over and over. If they're going out to a restaurant, it's not just pulling up the menu to see what kind of food it is. They're really evaluating the menu and really almost researching that aspect. And so those are some things that I think you could be on the lookout for. Like Shan said, a lot of this is internal. And I think there are some cues of that you could see some of that obsession coming out if you notice they're like researching restaurants and having that hard time because restaurants, they don't, or even wanting to be in the kitchen while you're cooking to see what you're doing all the time.
I would say the same thing with even food labels and certain brands of food, right? Like if you're in the store and they're researching and feeling obsessed with the food label.
Yep.
Yep. Great. Thank you for adding that. Functionality.
Yeah. So then this is where those behaviors, that obsession starts to come in and it's going to start affecting their life. This is when we start to move more into that eating disorder territory of now it's going to be affecting things like our social life, our self-care, family, relationships, academic, work. Those things are going to start taking a hit. You may notice that they're not wanting to go to family holidays because they know that there's going to be a lot of foods there that aren't safe for them, or they're worried about family members making comments on their appearance, and wanting to avoid those, as well as like not wanting to go out with friends, like Shannon mentioned, missing out because they know there's going to be pizza there. They know that the birthday cake is going to be there, and what are they going to do? And so instead of going, and figuring out in that moment, they just avoid it altogether. Or I've even had conversations with clients where they can't remember anything that happened at their friend's house except for what food was there. They don't remember the conversations.
Great point. We should probably add that. Like it gets to that obsessiveness gets so intense for them. You're right. They just have no recall of like what the games were that they played or what movie they watched, and because they're so focused. And that's what we're saying, like it takes them out of their present experiences. One that I've also found is the last one, changing and rechanging clothing multiple times a day. Again, there could be reasons for this, especially like now in the fall where it's colder in the morning and it's quite warm in the afternoon, right? They might come home and change into shorts and a tank top because it's much warmer. But if they are changing 4 or 5 times, or maybe not even 4 or 5 times, 2 or 3 times in the morning, and they're driven more out of how I look fat in that, or it doesn't fit right. That's another common phrase. Because the framework is now moving more into eating disorder thinking, and they're evaluating that from the eating disorder point of view. How am I going to be perceived? What is this going to look like? How am I going to feel all day? Versus like it's 100 degrees outside, I'm not going to wear a sweatshirt. Well, a lot of eating disorder clients will wear sweatshirts even when it's inappropriate weather for a sweatshirt. So we really want to look at clothing choice. That is going to be another one of the behaviors that will pop up. If clients also start refusing to go shopping, food shopping or clothing shopping, that would be another red flag that something's going on with that emotional piece that Sarah was talking about. Yeah. So when we're looking at functionality, we want to see, is there a change from how they used to, maybe a year ago, interact to now on all of these areas: social, self-care, family, academic, and work. Anything else that you would add, Sarah?
I would just add for the academic, noticing maybe your kid is keeping up their grades in school. Noticing though, is there a difference in patterns of what they're having to do to keep up with that? Because with that, when we're moving into eating disorder territory, it's harder to concentrate on those things. So maybe they are keeping up, and that's looking different for them because they're having a harder time.
That's a great add-on to that. Okay, so as Sarah mentioned in the very beginning, we are going to only address 4 primary types of eating disorders. Please be aware that any of these can have subtypes, and there are elements of them that could even, maybe you're not going to meet the full diagnostic criteria. So these can also be, there can be like atypical anorexia and things like that. But these are going to be our primary eating disorder elements and categories that we're going to go over today. We're not going to hit every single one. Let me show you this slide. Like, we don't need to read through this necessarily for you. What we want to do is just identify what are the significant factors in each, which is the characterized by, and we're going to also show you how there is quite a bit of overlap in this. So Sarah, why don't you start us off on anorexia?
Yeah, so when we're looking at anorexia, we're really looking at the restriction or inadequate food intake. So this is kind of that starting point where we're cutting foods out and we're not eating enough to sustain,
or like base metabolic.
yeah, to sustain our needs. And so there are different types of anorexia, like Shannon was mentioning, the different subtypes. This is where you're going to see clients or, people start to refuse meals. They're going to start restricting that food. And there is a really big element of that fear of weight gain here, fear of that body change, and you will notice that those kind of obsession of that body weight and size come into play.
Yeah, with the last point on this one with anorexia is that there's usually a pretty significant lack of recognition of how serious their low body weight might be. They might still actually have the perception that they're overweight, even though they're markedly underweight. So you want to really notice if those kinds of things are occurring. If somebody can recognize, like, I know that I'm underweight, and I can also experience like the headaches or the lack of concentration, and that's a good sign, because there's a healthy amount of awareness there, and usually a little bit more, well, I guess I could say a little less resistance in getting treatment for that.
Mm-hmm.
A lot of people do not know that anorexia is not just restricting. So we did put on here, there is binge purge behavior. They often can happen together, or we can simply have clients that won't binge and purge, they just restrict. So that is why we put those subtypes on here, because a lot of people don't realize that. They think if you're binging or purging, you must have one of the other eating disorders. So moving into bulimia, again, you'll notice that there are some periods of overlap. We do have an emphasis on body weight. We also do not want to gain weight. But the primary distinguishing factor here is the frequency of binge eating and then having compensatory behaviors. That's our fancy word for saying, what do we do to compensate for having eaten? So this is where you might see the excessive exercise, use of diuretics, laxatives, like thermogenic kinds of substances. And the clients will restrict in response first, though, to the binge. The binge usually starts first and then they restrict. I would say in the early stages. Later stages, it might not be that way. Anything else that you would add on this one, Sarah? Why don't you take this one? Binge eating.
And then, so binge eating disorder. So this is where people will consume large quantities of food within a 2-hour window period. During this time, people may feel like they are not even fully present when this is happening. And I feel like that's a really like key thing that we look for and talk about during binge eating is we're kind of this feeling of like numbing out.
Yeah.
Whether that we're trying to numb emotions out, but they don't even, typically there's not that fully present awareness of the amount of food that is being eaten in that moment. There is a lot of emotions that are attached to those episodes. And I think the main thing that I always like to point out about binge eating is because society will be like, this is where people eat a lot of food. And this is actually an eating disorder that is rooted in that like restriction of foods as well. So, you know, not eating all day and then coming home and we're binging at night, or we have this mental restriction of food that these foods are off limit, which then leads to those binges. So I always just like to point that out because I do feel like that part gets missed in society. But looking at these points down at the bottom, this is kind of where that emotion comes in. One may feel embarrassed. This is most likely going to be happening in secret, usually typically at night, maybe in their, like they'll do it in their car or when no one is around because they do have a lot of shame and feel guilty afterwards as well.
Yeah. So one notable piece about binge eating disorder as well is that other than the balance that the people who experience this might have in terms of restricting and then binging, there's not the very structured compensatory behaviors like we see with bulimia. So it may not be that I'm restricting any particular kind of food. I just am not going to eat, period, right? They don't typically engage in laxative use or any of those other behaviors. They're not purging. They're also not typically over-exercising or exercising in response to having eaten. So this is a really distinct eating disorder in that way. There's lots of emotions, but there's not lots of compensatory kinds of behaviors. So that's one way that we would differentiate that. It's also one reason why sometimes in treatment centers, they have a different track or a different treatment protocol for binge eating, because the thought processes are very different from anorexia and bulimia. Anorexia and bulimia can often be treated like in the same cohort, if that makes sense, in a facility, because the thought processes are very similar. They just are manifesting in slightly different behaviors. But with binge eating disorder, the thought process is quite different. Okay, this one has gotten a lot. ARFID is what we call this one, the avoidant restrictive food intake disorder. So this has gotten a lot of visibility, I would say, in the last probably 5 years, Sarah?
Yeah.
Yeah. We used to really only see this primarily with children. Sarah and I still believe that this is primarily a youth-based eating disorder, that adults typically would have already advanced into one of the other kinds of eating disorders. Adults usually will have the fear of weight gain or body disturbance, the way that they're viewing their body. But people who struggle with ARFID, it is really more about the reaction to the food, the texture, a fear of gagging, a fear of choking, a fear of vomiting, that then gets linked to a certain kind of food. They don't typically demonstrate that they have significant distress about how their body looks or an experiencing of their body. I would say they're more in the normative range. Sarah and I kind of joke that if you're growing up in America, you kind of have some body image issues.
Yeah.
But they don't have, their disturbance might not rise to the level of anorexia, bulimia. So you're going to see that this is really just more a failure to gain weight or a failure to grow and develop according to their natural growth trajectory. So this is where we do see it really more in children, where picky eating can then really advance into refusal to eat. Or if there are some like occupational therapy methods that could help in terms of relearning how to swallow if there were significant illnesses. Kids who have allergic reactions will have a heightened incident, in my experience, to developing ARFID, because the allergic reaction is frightening. It's scary and it's very uncomfortable. So if we have certain foods that we're allergic to, that can then create more distress around foods and more restriction. I mean, we don't want people eating foods that they're allergic to, especially if it's anaphylaxis. But I'm leading to, like, what are some of the factors here? Definitely, it's still characterized with the functional impairment. So you would still see like kids that don't want to go to birthday parties, or kids that don't want to go and eat out with grandma and grandpa, things like that. But primarily, we're looking at what is the degree to which food is being restricted, certain types of food due to texture or smell or general appearance, that is getting in the way of developmentally appropriate weight gain.
Yeah. The only thing that I would add on to this is that every person that I have met who has this diagnosis of ARFID, every single one of them looks different. They all have different foods that feel safe to them, different foods that feel fearful. It's very individualized when looking at this diagnosis. And so it may feel confusing sometimes, of like the different foods, like why this food and why that food. And sometimes the child doesn't even know like why. That can feel confusing and frustrating. And so I just want to validate that.
Yep, I would agree with that. I think that there are probably more general commonalities of typical foods that somebody who's restricting might not want to eat if they have anorexia or bulimia. But with ARFID, it is very, very individualized based on those experiences that have contributed to it.
Mhm.
So their particular illnesses or their particular experiences with certain foods. I wouldn't say that there's like traditional foods with ARFID clients that they will across the board want to restrict.
Yeah.
Great point. Okay. Who is at risk? Sarah, start us off on this one.
Yes. So to give a blanket statement, anyone can have an eating disorder, anyone and everyone. So there are some factors that are going to put people at greater risk for developing an eating disorder. So we do have the biological, the social, and the physiological aspects that can trigger some of those behaviors in eating disorder. Starting off with biological, eating disorders have a really big genetic predisposition to them. So I always like to talk about this and really bring it forward because people with an eating disorder did not choose to have an eating disorder. It is like any other disease where it was not a choice.
Yeah.
As well as having that family history and a history of dieting as well to bring in a statistic. 1 in 4 people who go on a diet will develop an eating disorder.
It's astounding when you think about that.
Yeah, that's a pretty big percentage in my opinion. And then looking at the physiological, the psychological, sorry.
That's okay.
Looking at that body image dissatisfaction, that low self-esteem, having another diagnosis of anxiety, depression, OCD, ADHD. These are diagnoses that we see very commonly in with eating disorders.
Yeah.
And then also having that perfectionism trait of having to feel that perfect or feeling even feeling inadequate or incapable of things are going to put people at more of a risk for developing an eating disorder.
Yep.
Looking at some of the social factors. So this is where society comes in. So I talked about
we could do a whole webinar on just the social factors.
Yes, I agree.
These are
I talked about at the beginning, society really normalizes a lot of these behaviors and a lot of these factors. There's a lot of weight stigma in society. I talk to clients about just because something is normalized doesn't make it true. So really looking at the things that are normalized in society and how those affect, as well as if someone has a history of trauma, someone going through really big life changes. So a lot of stress that's coming into life, because what we know about eating disorders is they're actually a coping mechanism that can come in for those things. And so someone who has the history of those things happening, it does make sense to us as providers that this coping mechanism came in. And then also looking especially at weight-centric sports. So things like dance, wrestling, those things where gymnastics, where weight is really talked about publicly to a lot of people, and where appearance is going to be brought up a lot, can also increase risk.
I've noticed there's a high incidence also of ice skaters, because there's a tremendous comparison process going on there, and how do they appear on the ice, and a lot of things too. So we definitely want to pay attention to the athletic elements of it. Coaches can unintentionally endorse restrictive patterns. So I think the when we talk about diet culture, Sarah and I are also talking about like the clean eating craze, where there's moralistic overtones to what foods we're eating. It's clean, or the alternative is that it's dirty, that something's wrong with it somehow. So I really do think that the major life challenges or major life changes is a piece to pay attention to. We frequently see for anorexia and bulimia, the emergence of it as a full disorder at big periods of shifts. So puberty, where bodies are changing from a child's body into an adult body, and those changes and the appearance that goes along with it, as well as the internal experiencing, can be very dysregulating. And like Sarah said, clients can start using eating and exercise as a coping skill. The other times that we see it emerging, if it's not during adolescence, would be during childbearing years, or even much later when women are done with childbearing and their bodies are shifting again. We can see very restrictive patterns with women in menopause as well. So really paying attention to, like, when a young adult is going to college, they're going to be at a higher risk for developing an eating disorder because of all the changes that are happening. And there's a sense of efficacy and being capable if we are very structured about our eating, or if we believe from the more bulimia side that I can do X, Y, and Z and just compensate for it in this way. That gives us a feeling of mastery.
Yeah, and even thinking that's when that perfectionism trait could come in. So
Yeah,
if you have, like, we're thinking about these factors when they start to compound against each other. And so they start to kind of stack up, and then that's really putting them at that risk.
Yep. I did want to just clarify, there is a difference between what we're talking about for genetic predisposition versus a family history. I mean, clearly, if you have a family history of it, there could be a genetic predisposition. But I asked one of my mentors long ago, like, what does that mean? And it was explained to me that people who particularly have anorexia have some element in their DNA where they don't experience the physiological distress as significantly as somebody who doesn't develop an eating disorder. So what I'm talking about here is, if I go 6 hours without eating, I start to get grumpy, I start to get a headache, I might even feel a little sick, I might feel very weak. But somebody who is who demonstrates this genetic predisposition doesn't actually, like, internally experience that distress. So this enables them to have excessive amounts of restriction and still, in some ways, might actually be able to be pretty high functioning. And we don't know a lot about this yet. We're still learning this and researching it, but that kind of blew me away. It helped me understand how somebody could get so entrenched and reliant upon restriction because they don't actually experience the way that somebody who isn't going to develop an eating disorder. It's fascinating to me. Okay, let's move on. Here are our warning signs. So the behavioral signs and the physical signs are things that we want to look for together. This is also a way, like, if we're just seeing one of these, right? Like a kid wants to eat alone at school. Well, that could be for different reasons. If it's not combined with all these other things, it's not necessarily a sign that they have an eating disorder. And I do want to just reiterate what Sarah said, that there is no selectivity with an eating disorder. Eating disorders happen across all genders, across all nationalities, ethnicities, all of it. Nobody is actually immune from developing an eating disorder. So we really want to pay close attention to these. So here on the behavioral signs, we really just want to look at what are their choices around weight loss, dieting, and specific eating behaviors. This is naturally then going to require that we have some joint eating experiences as a family or with our friends or partners. If we're checking in the mirror, or I would say any reflective surfaces, when you walk past TJ Maxx and their glass doors, if you see your child like adjusting their clothing or kind of checking themselves out, giving themselves a side eye, that would be something to be like, hey, what's happening there? Sarah and I are both proponents of not weighing ourselves. The doctor can weigh us if we are curious, intermittently every 6 months or a year when we go for our yearly exams. But if a person is weighing themselves daily, that is a very significant warning sign. Okay. Eating alone, or skipping meals, eliminating food groups, eating alone, hiding food. would alert me more so than just eating alone. Eating alone, it could be more like, oh, I got rejected today. I feel kind of down. And I just kind of want to be alone. But if it happens consistently, or they're hiding food. So if you find food in bedrooms, if you find food that you didn't purchase in their backpack or stashed away in their car, these would be concerning signs. We've talked about the decrease in socializing and isolating due to or around meal times. Behavioral signs that are also emotional would be increases in irritability. This is going to be a key factor. When they're asked to eat something that they might not like, how upset do they get?
Mm-hmm.
And then a behavior of excessive exercise with the goal to change the body shape or size. Now, this is where it can get tricky if they are in an elite sport and they are required to have, 2-a-day workouts. Sarah and I would probably be like, oh, that's a little concerning. Then we would look at the other factors. What's their evaluation of themselves and their body? Are they trying to change something about themselves, or are they trying to excel at their sport? It's a slippery slope, so we really want to be mindful of that. But just because somebody is exercising a lot does not mean that they have an eating disorder. We want to look at why. What is driving that? What is the motivation behind it?
Yeah, and even thinking with those sports, I know 2-a-days comes up a lot.
Yeah.
I would even say what I've seen in clients is then they're going home and doing their own exercise after those 2-a-days, and being like, well, I have to practice more. And so really looking into the why behind that.
Yeah, that's a great point. Yeah, great point. Other physical signs, behavioral can also be physical, right? What they are eating or not eating and such. But the physical signs in the body, if an adolescent, they have their growth curves, and if they start falling off their growth chart, either height or weight, what that would look like actually is the dots of where we're measuring actually stay level, or in really severe cases will go down. And you'll notice that there's lines on the growth chart. But one of my other dietitians taught me, and my mentor taught me, if they cross 2 of those lines, like within a 6-month period of time or a year, that's a concern. That is not developmentally meeting their growth progression. So we really want to look at that. This is why Sarah loves looking at growth charts. Here, loss of menstrual cycles in cis females. So if we are restricting to such a degree that our basic body function of menstruating stops, that is almost 100% going to give us a concern for an eating disorder. When clients start rebalancing their nutrition as well as their nutritional intake, the body will begin menstruating again. So this is really a survival element here, where the body is going to communicate. We cannot take the risk of getting pregnant and sustaining another life. Our own systems are not well supported enough. So please pay attention if a cis female has had a regular period and then has stopped menstruating for, I think it's 3 months or more. If this is a child, however, that has just started their period and they are irregular in their cycle, that would then just be something that we factor in. It could be related to restriction, but it could just be the natural course of our body having to regulate itself. Brittle hair, feeling cold, low heart rate or low blood pressure. These are things that Sarah will monitor as a dietitian in her appointments. She will take vital signs and will really be paying attention to that. Persistent dizziness or lightheadedness. This is simply because the body is not getting enough food. Or if they faint often, if that lightheadedness and dizziness actually creates a fainting cycle. And persistent fatigue or weakness. This is because the body, again, is not getting enough energy. So these are the warning signs, behavioral and physical, in the body that we're going to see. And we've already talked about what the emotional internal signs are, but the warning signs are going to be things external that you're going to be able to notice. It's a lot harder to notice the internal processes, like what's motivating the fasting, what's motivating the restriction, what's motivating the exercise. Those you're going to have to ask about. These are ones that you can behaviorally just observe. Anything else that you want to add?
On the physical signs, I would just add that Sometimes the body is really, really resilient and may not show some of these warning signs. So someone who has a full-blown eating disorder, they may never lose their menstrual cycle. And that doesn't mean that they don't have an eating disorder. It just means that their body is fighting really, really hard to keep these systems going. And the body is just resilient regardless of the behavior.
And that's going to speak to the genetic piece. There are some people, right, whose bodies can demonstrate tolerating that more than others.
Yep.
And we don't know. We can't gene to test for that. So, okay. All right. Level of care. I'm trying to be mindful of the time that we're taking. So, Sarah has worked at residential, so I'm going to let you go over these first two here, and then I will do the PHP and IOP one, since that's been more my.
Yeah, perfect. So when we're looking at levels of care, the highest level of care that you can be at for an eating disorder is inpatient. Inpatient is going to be looking really at just stability medically and the psychiatric stability. Their sole purpose is they just want to get you stable. It's going to be a very short stay. Typically, they're trying to get you in and out. They just want that stability. Then the next level of care would be moving down to residential. So residential is where you are medically stable. There are still impairments that are there though. So at residential, you live at a facility 24/7 with staff there for support. So this means that you are going through treatment and you're going to have multiple groups. You're going to have an entire team. So if it's eating disorder, you're going to be having your dietitian, you'll have a therapist, you may have a family therapist, you're going to have a psychiatrist, you're going to have a medical provider, there will be nursing there. You will have a full team that is going to be there to support you. And there will be different exposures. There is a structure schedule. And really the residential takes control of a lot of elements around like food to help put in place like normalizing eating throughout the day or looking at feelings and all these things. So.
Yeah. Now, if you are tracking through this, you are living there. So this could really create some problems for a parent because you're not going to be able to be at home taking your kids to school or going to their sporting activities. So this is a significant disruption. And it is necessary in order to continue the stabilization that occurred in the inpatient. So kids will be pulled from school and will be able to do school at their residential facilities. I think it's usually about 3 hours a day, maybe.
Yeah, 2 to 3 hours.
2 to 3 hours. There's dedicated time where they can meet with district tutors, private tutors, do online kinds of educational processes so they don't fall behind, because we don't want kids to fall behind academically. However, for the parent, it's going to be essential if you're doing residential that you've got other supports and people who can help with your children. We do really want parents to understand that it is very important for them to do residential because they can then get healthier and healthy enough to go back into the family setting and function in the way that they want to for their children as a parent. Okay, here is, this is where I spent a fair amount of the last decade of my professional experience. Partial hospitalization program is abbreviated PHP, and it is a full day treatment, but you go home in the evening and or the weekends. There are some variations in programs. Some are 7 days a week. Many are only 5, so that you can have a little bit of practice being, multiple days on your weekend with the family. You do still need to demonstrate medical stability, but there is still some impairment. There's either continued binging or struggles with restrictions still and fear foods. This is going to turn into much more well, not much more. There's still a lot of therapeutic groups, just like at residential, but we're giving a lot more of the motivation and responsibility now to the client because they do go home in the evening. You're typically having 2 meals and 2 snacks at PHP. And so you're having some individual eating experiences outside of the clinic setting to practice some of those skills. When you get stable enough there, then you step down to intensive outpatient, which is both a reduction in hours per day as well as days per week. And then many programs will titrate that or move that down gradually. Again, still need to have medical stability, but you're not really requiring daily medical monitoring like some of the higher levels. You still have appointments with an RD, with a family therapist. At this point, you can also start reconnecting with an outpatient therapist if you had one before, or start developing a relationship with an outpatient therapist for whom you will meet or with whom you will meet weekly once you're all done with IOP. So there's a little bit of an overlap. This is often really I find the trickiest level of care because clients and patients still need more support. They're not quite ready for completely self accountability. And it's dropping down kind of quickly. So we do see the potential for relapse when clients are at the intensive IOP level. And sometimes we restore them back up to partial again to just solidify some of those skills. So I want to just prepare people like you move back and forth through these levels of care sometimes more than one time. When they are really finding pretty solid success, pretty solid patterning, having restored weight or reduced incidences of binging and purging, then clients see people like me and Sarah. You would see your therapist weekly, doing some family sessions as well, and you'll have initially, I think our recommendation always was that you would meet with the RD weekly, then stepping down to 2 times a month, and then stepping down to monthly as you progress. Is that your understanding as well, Sarah, or has it been different for you? Yeah. That also can really depend. Some clients may like do weekly sessions for a month and then drop down right away to once a month and keep it there for 6 months. Others might need to do weekly appointments for 6 months. It really depends on the severity of the eating disorder and how long the duration has been that they've been practicing it. Anything else that you want to add on this?
No.
Okay.
So these are just looking when providers are considering what level of care would be appropriate. These are some things that we have to take into consideration. What is the medical status? And, are there any other disorders that are happening at the same time? What the availability of treatment? There are just many factors that we have to consider. Ultimately, when we're looking at level of care, we're looking at like what kind of support does that person need, and how much of it is kind of that bottom line.
Yeah. So this is really a structured process for Sarah and I. We will go through, and this is why our assessments can be an hour each, so that we are really gathering all this relevant information. We are not just meeting with somebody when we do an assessment and say, well, we think you could really benefit from residential. It doesn't really work that way. It's based on necessity. So we have to be able to look at your signs, symptoms, and experiences and slot it into what Sarah's talking about with what level of support and the intensity of support do you need to make the necessary changes to get back into a healthy range with eating and or weight. So we just wanted to show this to you so that you're aware of what goes into an assessment and that there are clinical reasons and justifications for the recommendation. We can't just, we can tell somebody, you could do whatever you want. You want to go to residential, you can go to residential. But your insurance company requires these pieces in order to get the medical coverage for it. So we just want everybody to understand this is not just our opinion about something. This is actually, is it present or not present, and to what degree? Okay, how you can support your teen. So I would actually say, yeah, we added loved one. Yeah, okay, good. We work very diligently to help parents and partners reflect on your own beliefs. If as a mom, I'm consistently mirror checking, I'm weighing myself, I'm commenting on my body weight, or I can't have that food because I'm working so hard at trying to be good on my diet, those are tremendously loaded statements that will impact our children. Many of us that struggle with eating disorders can look back to comments like these from either parents, grandparents, extended family members, coaches, or even health teachers in school. So we want to reframe from talking about our bodies to like positive personal traits. So instead of if somebody has lost weight, what Sarah's talked about in terms of our society endorsing a lot of things, people will be like, you look amazing, you look fantastic. And where we want to focus it is, it's so great to be with you and to see you. I'm so glad you came to this party.
Mhm.
And not really address their physicality, their body size, shape, or appearance. Next one can be a tough one, not commenting on what our kids are eating, how much they're eating. Are you sure you really need to have that second helping? Those kinds of comments, while they may be well-intended, are actually comments that a child can internalize as shame, that they shouldn't be doing something, or that they're wrong or bad for doing it. So we want to model normalized eating. Can a parent eat a food that they don't particularly like? And model, like, a preference is not the same thing as refusing. I might prefer, my husband and I joke about our chocolate preferences. He likes dark chocolate. I like milk chocolate, but we can both eat the other kind of chocolate. It's not like I will refuse to eat dark chocolate. We want to come from a curious place. Help me understand this more. Help me learn more about that. Can you tell me more about what that feels like for you? That's going to be a key component when you're trying to understand. You see behavioral signs, the ones that we had talked about. This is going to be the type of question that's going to really help you get to the underlying emotional part. What are their beliefs about themselves? What are the self-talk statements that they're making? And if you have some concerns about what the child or a partner responds with, then seek some support from professionals like Sarah and myself. We're happy to help you parse it out and to learn a little bit more about it. These are just the links. Sorry, go ahead, Sarah.
Yeah, I was going to say these are the resources that we added. So there is the National Eating Disorders Association with the helpline. Anytime you Google eating disorders, this will be like the very first thing that pops up on Google to give you a lot of resources. And then nationally, and then looking at regionally for Texas, we included Eating Recovery Center, Center for Discovery, Montanito, Clementine, House,
Alsana.
Alsana. Sorry, I've never said that one out loud.
Yeah, I know. Yeah.
These are all going to be different treatment centers that have different levels of care, from all the way from inpatient to IOP.
Yeah.
So.
And this is where, if you are curious about it and you aren't sure if you or your loved one has an eating disorder, you can come do an assessment, a full assessment with Sarah and I. I'm going to do the therapeutic piece of it. Sarah will do a full nutritional assessment, take a look at labs, understand your vital signs and how that's communicating something to us about what's happening within your body. And then we combine those together. We do have 5 or 6 different standardized assessments that we also will use to screen for depression, anxiety, and trauma, as well as some body dysmorphia. So that is one of the other diagnoses that we didn't really get into, but sometimes has overlap with that disturbance in how we view our body. And then we will assist you in an admission to any of these higher levels of care should you choose to accept that recommendation, if that is the recommendation. We have relationships and connections with all of the people at these facilities. And so we will share our full assessment, so you don't have to keep going through multiple assessments and getting very fatigued and worn out with it and overwhelmed by having to talk about your story and your experiences over and over again. I would say, I think all of these, except almost all of the major medical insurance policies. This is what we do at Connections Child and Family Center. We have now, I think, 17 clinicians. We do individual, couples, group, and family therapy. We have a full DBT comprehensive program now that we are running as well. And Sarah and I are designing a DBT comprehensive program that will be specifically for clients who have struggled with eating disorders. So that's up and coming soon. We do child therapy, and we have several doctoral clinicians who can do testing for all different kinds of things for children and adults. So we provide a wealth of services for a variety of different people, kids, adolescents, and adults as well. If you want to get a hold of us, I think I put this in the workbook that we also have available. It's a PDF, you can download it, but you can reach us at connectionsfamilycenter.com, and you can review all of our services. And then if you do the /contact, that's how you can set up an appointment for an assessment with with both Sarah and myself. I think that about covers it. These are the rest of the slides about the statistics and the evidence-based information about how frequently people are developing eating disorders, what are some of the subgroups. You can see we've got a lot of information here on thin ideal, diet culture, and then our references that we rely on and have pulled from for all of the information in our presentation. Is there anything else that you want to add? We're a little bit over an hour, but anything else, Sarah, that you want to add? Okay.
No, I don't think so.
So please give us a call if you're interested in it. There is support. You don't have to experience this alone. And if you just are not sure, we can help you determine that as well. And we can provide services no matter what your experience is. If it needs a higher level of care, we can help you do that. And if it's at outpatient, then Sarah and myself and some other clinicians could definitely help you. All right. Thanks for joining us. And if you have any questions, go ahead and email those contact or the links. You can email those to us from our website. Okay. Bye.
Thank you.